Our next panel discussion is called What's in Them Genes? Let's learn about AMKD. This is a conversation about AMKD and the impact of genetic factors in kidney disease. And of course, we are honored and privileged to have Dr. Kemi Williams moderating today. She leads global patient science at AstraZeneca and is a driving force behind inclusive research and equity in care. Joining her are three incredible voices. We have Dr. Daryl Crenshaw, a nephrologist and educator whose work spans clinical care, national advocacy, and mentorship. Alongside Dr. Crenshaw will be Joshua Albright, a speaker and youth coordinator whose journey with FSGS powers his mission to educate and inspire. And last but certainly not least, Jorden Albright, a leading advocate and consultant reshaping how patient experience drives outcomes in APOL1 kidney disease. And of course, we can't forget to mention that this session is made possible by our platinum sponsor, AstraZeneca, and we're grateful for their support in amplifying conversations like this. So let's give them a warm round of applause. Welcome to the stage. The floor is yours.
Good morning. I hope you're all doing well. My name is Kemi Williams, and it's an honor to be here with you all today at the Black Health Matters Summit. For me, this is a gathering that reminds me of the power of community, science, and advocacy coming together in one place. For our session today, What's in Them Genes? Let's talk about AMKD. We will be talking not just about a medical condition. We will be talking about lives, futures, and the importance of representation in clinical trials. I'm sure you've heard of all about that before. So focusing on what is called APOL1 mediated kidney disease. We also call it AMKD. This is a rapidly progressing chronic kidney disease that disproportionately affects people of West African ancestry, particularly African Americans. Well, here's the interesting part of this disease. Knowledge and awareness of the disease is very low. So we're hoping to change that today, as well as access to clinical trials that could potentially drive better healthcare outcomes often is very limited and not equitable. So our goal today is to bridge that gap. We want to deepen your understanding of the disease. We want to share lived experiences and then highlight the important role that each one of us plays in ensuring that science works for everyone. And so you would hear from the patient's perspectives and the physician's perspectives about the risk factors for the disease, as well as what it means to be diagnosed and what the impact of the diagnosis is on your daily life. And then what does it mean to participate in a clinical trial? So it's my privilege to welcome our panelists today. I'm going to pass on the microphone to them. They get to talk a little bit about themselves. And then Dr. Crenshaw will do a brief presentation giving you more background and history of the disease so you can really understand what this means for everyone. All right, can you go on?
Of course. Hi, everybody. My name is Joshua Albright. I'm 22 years old. I'm a college student at Georgia State University in Atlanta. I'm also a youth program coordinator, so just using my passion to uplift my community. Appreciate it. Just be a positive voice, and I'm also a patient and a public speaker, so it's a big passion of mine to use my story to, particularly give back to my community and talk to people who look just like me, who have journeys that are similar like me, and just, give some more knowledge to my people. So appreciate you guys for being here.
Good morning, y'all. I'm Jorden Albright. I'm 27 years old. I am Joshua's brother. I'm also an AMKD patient, director of Rise Property Group, community leader for Neck Your Kidney International, and get to do cool things like this with my brother from time to time. So happy to be here, and I appreciate all y'all.
Good morning. I'm Dr. Daryl Crenshaw from Thomasville, Georgia. I'm also a clinical professor at Florida State University College of Medicine, along with Philadelphia College of Osteopathic Medicine. I have a strong passion for this disease, and I'm so excited to be here. Thank you.
Awesome. So next thing, Daryl, we're gonna have that presentation ready. You can go to the podium.
Okay, good morning once again. So for the next few moments, I want to talk to you about APOL1-mediated kidney disease, a disease that is affecting worldwide anyone who has some underlying African ancestry. And for pretty much everyone in this room, you could be affected by this devastating disease. Most of us know that kidney disease in the United States is at alarming proportions and is affecting many, many people in this country. We understand now that about 37 million Americans have kidney disease, but the caveat is that most do not know they have it. African Americans make up 13% of the United States population, but here's the fact, comprise about 35% of all kidney disease in this country. So we see a tremendous disproportionate number of people of color affected by kidney disease. This is why it's so imperative that early detection is critical for prevention and treatment of this devastating disease. Okay, so we understand this disproportionate impact on certain communities, in particular, increased risks of individuals with African ancestry. And so this would include Blacks, African Americans, African, Afro-Caribbean, Hispanic, or Latino individuals. And so we understand now that anyone with this degree of lineage may have a link to the genetic variants affected by APOL1 gene. And so understanding the APOL1 gene, we understand that everyone in this room has the APOL1 gene. You get one from your mother and one from your father. However, some carry one or two risk alleles from ancestors from Central Africa. And so, unfortunately, if you have two of the high-risk variants of this gene, there's about a 1 in 5 or about a 20% likelihood you may develop kidney disease. And we have called this particular kidney disease officially APOL1-mediated kidney disease, or you may also hear it as AMKD. And also there are variations of this disease presentation. Most appear with chronic kidney disease, but many people for decades have been misdiagnosed as having hypertension-related kidney disease. And now we understand what APOL means because it can also present in the form of what's called focal segmental glomerulosclerosis, or FSGS. Both forms of the disease, whether it's hypertension kidney disease or APOL1-mediated kidney disease, presents with scarring and eventual kidney failure, unfortunately leading to many people developing dialysis and the need for transplantation. What is the risk and how common is the risk in this country? At least 50% of Black Americans have at least one of the APOL risk variants. And having two of the APOL risk variants increases your chance for developing kidney disease. And so fortunately now we can detect risk with genetic testing. The only way you can really understand APOL1 risk status is through genetic testing, either through a blood test or a swab of the cheek. Treatments for developing this disease and for treating this disease are currently right now pending, and that is very fortunate for us because it's very important that everyone in this room who has some underlying history of kidney disease in your family, I think it's very imperative that you reach out to your provider to see if you qualify for the testing of this disease. Thankfully, also, advancing treatment through research now has emerged. We understand that clinical trials now are right now available to find out new ways to treat this devastating disease. And this is why it's important to participate in clinical trials to help those who have high-risk APOL1 genotypes be able to be tested and further treated for the disease. And so testing and support right now for anyone, there's testing available, particularly if you fall under the categories of being Black, African American, Afro-Caribbean, Hispanic, or Latino, you may qualify for the testing. And certainly keep in mind that also diabetes is one of the top leading causes of kidney disease worldwide. So you want to be able to distinguish whether you have diabetes or actually have APOL1-mediated kidney disease or have hypertension. Certainly, you want to be tested before you eventually require dialysis or the need of renal transplantation. And thankfully, too, there's genetic counseling that is available around this country to be able to assist you if you test positive for APO1 mediated kidney disease. Thank you.
Thank you. Thank you so much, Dr. Crenshaw. And just for everyone, we will have a question and answer session when we're done with this discussion. But you've heard a little bit about the disease, right? I hope you understand what it means now. Now let's hear from Joshua's and Jordan's perspectives what it means to live with the disease and what they're doing right now to manage their care. So I'll start with you, Joshua. Can you tell us how you felt when you heard about your diagnosis and actually the story that led to your diagnosis?
Of course. So just to start off, before being diagnosed, I really had no symptoms at all to be able to tell or have any inclination that there was anything going wrong with my health. I was an athlete before. I grew up with my dad as a chef, so we always were eating healthy and, thought we were doing all the right things. Well, basically, my aunt had given a kidney away to another family member, and we stopped by her house basically just to check on her. And she had a blood pressure machine out so she could check her blood pressure. And my sister and my cousins were playing around with the blood pressure machine. They put the cuff around my arm, and my levels were extremely high. At that time, I was 17, turning 18. I could care less what my blood pressure said, to be honest. I was trying to go see what the plan was that night with my friends. But very quickly, the next day, my mom actually reached out to my primary care doctor, and they let her know, that I should be rushed to the urgent care just to kind of get a follow-up or have a visit to see what was going on. When I got to my doctor's appointment there, my blood pressure was extremely high as well, and I think that's when it finally started to click that it could possibly be something. Luckily for me, in my journey, within 6 to 8 weeks, I was able to go through getting a kidney biopsy, finding out, that I was diagnosed with kidney disease, and basically was able to create a treatment plan with my doctors that just worked out perfectly for me and my situation. How I felt when I first got diagnosed, to be honest, it took me a long time to even process what that meant as an 18-year-old being diagnosed with kidney disease. But I think when it finally clicked, the first thing that you initially feel was just the fear, the uncertainty, not really knowing what your future is going to hold or what it'll look like. We all know when you get a symptom or you get a diagnosis, the first thing we probably all do is go to Google. Hop on Google. I hopped right off Google when I saw what it said on there. But luckily for me, I was caught at stage 2. I'm still at stage 2 to this day. My care, which I'll get into a little bit later. But my care that I got when I first got diagnosed was very crucial in my health where I'm at today. Early detection is very important, and it's been an amazing journey, as crazy as it sounds. But for me and my brother, we've been doing very well. So.
Thank you so much for being brave and for sharing your story with us. Did you have to change your lifestyle in any way after getting the diagnosis?
I actually did have to change my lifestyle a lot, and I think to this day it's still an adjustment. Just learning, I can't live the same that I was before. I think every decision that you make is a lot more intentional, whether that's with your health or with your mental. Just every day is just a lot more intentional. And also, getting to college and being around certain friends and whatnot, I know I can't do certain things that, the average 20-year-old, 22-year-old is probably doing. So it's a little different, but it's definitely worth it. So.
Thank you. And the interesting thing with this scenario is that we also have Jorden here, his older brother, who also has been diagnosed with AMKD. Now, I would like Jorden to share his story about his own diagnosis and how you felt and what other lifestyle changes you had to make since you heard.
Yeah, I felt very surprised, really, because, I remember the moment my brother got diagnosed and all the cliche things people say, like the world stopped, and like, man, like it just felt so like, this is crazy. Like, again, he had no symptoms, no prior thoughts, anything was going on. So we were just going with him, trying to support him in the way we could. He wanted to share his story and spread awareness, and I'm out there with him just trying to watch and support him. And then the whole time I have the same thing. So by the time that it was official, in that moment, it really mostly was surprise, like shock. It's like, what are the odds of this happening? But I didn't get that same feeling of like that dang moment. It was just like, it didn't hit me as hard because my brother was already going through it. So it felt like something that we can at least go through together. So it made the hit for me a lot easier, I'd say. And as far as me getting diagnosed, it was a lot more streamlined after that because our mom is a force to be reckoned with. So she was already doing all the research. She was out there. She was on top of all of us, and she pushed all of my. So we have 5 siblings that pushed us to go to the doctor, make sure we got our protein checked, our general physicals, and I had a bit of protein spillage, and I was like, okay, well, but I probably don't have it, right? So like, what do I need to go back for? She keeps pushing me, and I was able to get genetic testing through organization FCure and through a trial that Joshua was about to participate in, and it preliminarily said that I did have the variants present, and that led to me getting my biopsy and confirming that I as well had APOL1 FSGS. So it was all pretty fast, and for us, it kind of just further reiterates the fact of how important early detection is, because as Josh said, I'm also in stage 2 still. My EGFR is in pretty solid range still. It's fluctuated a bit like all of us does, but you know, it was a lot more streamlined for me with my brother already going through everything and our family really kind of being there to support us and make sure we make the right decisions collectively. And as far as lifestyle changes, it was at a time in my life where I was trying to be a bit more on the straight and narrow, be a bit cleaner as far as my health, you know, getting back better in the gym, running, working out. So I was trying to get on that level of things anyway. But at the same time, it was a further reassurance of like, okay, like I got to really take this seriously, you know, and I got to get with my brother and make sure we're both doing this together in one way or another, because no matter what, we all got to be active. We got to take care of ourselves. We got to eat right. But I was like, okay, we have a genetic disease that makes us more likely to reach, you know, we have a more aggressive form. So things are going to happen how they do. Life's going to play out. So I got to do what I can, take what's available to me and what I can be in control of and run with it. So changed a bit, but it was easier seeing my brother already doing so and making sure we do it together and kind of pushing forward.
Thank you so much, Jorden. And shout out to all those mothers and sisters out there that are being the healthcare advocates and warriors within their families, pushing them to get tested. We need you to keep doing what you're doing. Thank you for your mom. Now, Dr. Crenshaw, I want to come back to you. Can you reflect on the stories shared by both Jorden and Joshua and tell us if that represents what you see in your clinical care?
Absolutely, Kemi. You know, when I see these 2 young men who are magnificent, you know, I think about my own family upbringing, and just for note, you know, kidney disease is very dear to me. It's perhaps one of the reasons why I became a nephrologist. I had a grandmother who died at the age of around 70 with kidney disease, was on dialysis. Had an uncle who died at 39 as a result of kidney disease, was on dialysis. I had a first cousin who actually had kidney disease, and thankfully he got a kidney transplant. And so kidney disease is very dear to me. And so when I see the presentation of these 2 gentlemen as a nephrologist, it's very, very classical. And I like to say in this room that unfortunately what happens to many individuals, because they don't know kidney disease. Remember, I showed you the slide. I said many individuals have kidney disease, but they do not know they have it. And what happens is when they come in my office, the very first question that I'm always asked is why I am here in this office. And so I think it's very important, particularly everyone in this room, that if you don't have a provider, I think it's very important to get attached to one, particularly if there's any underlying kidney disease in your family, because you may have signs that are early on that may not be recognized until you see a doctor and truly are tested. I'd like to say, yes, absolutely. What these gentlemen presented with is typically what I see. And part of the reason why I've become very passionate about pursuing and trying to mitigate this devastating disease, and particularly in people of color.
Thank you so much. And to add on to that, right, Joshua found out about it, right, through a genetic testing. And guess what? Jorden also went and got tested. So it's important, if we have family members who have been tested, that we know, that we start thinking that, okay, this is a genetic disease, perhaps it's good for me to get tested as well. So just wanted to throw that out there. Now, Joshua had the fortunate experience of participating in a clinical trial. So I want to understand from your perspective, What led you to being a participant, number one, and what was your experience like in a clinical trial?
So for me personally, I basically was put in decision for me and my family to sit with either going onto steroids for our treatment or being placed in a clinical trial. The doctor who actually did my kidney biopsy approached us with information that he was going to be coordinating a clinical trial that specifically was related to the kidney disease that I just got diagnosed with. I don't know if it's too many faithful people in here, but let's just say it's not too many coincidences. So it felt right for me. I felt like the way it was presented, it seemed like a hopeful opportunity. If you've heard the side effects of steroids, a lot of people already know what may happen when you get on steroids. It's plenty of side effects, and I thought the best decision for me in that moment was to try the clinical trial. Luckily for me, I was very fortunate to have an amazing care team, an amazing doctor who always makes me feel like more than just a patient, but also just a human. They care so much about me while I'm in the doctor, outside the doctor, my interests outside of, kidney disease. And we just always built this bond in this relationship to really have that trust. I was also, like I said, diagnosed right before college. They gave me the flexibility to be able to coordinate at-home visits. And to be completely transparent and honest, I remember when I was in college, I felt like I looked at my kidney disease as like a weakness. I didn't want everybody in the dorms knowing I had a nurse to come and check on me. So I would actually go all the way home to my parents' house and they would have a nurse meet me there. I'd have at-home visits. They just made being in a clinical trial not a harder experience. Some people are placed into certain trials or certain things and it actually makes it a little bit harder on them. It's not as easy. They don't coordinate it the way that it puts the patient's life first. So I'm not going to be the person who sits and tells everybody the clinical trial is the best option for everybody. I think the question is how can pharmaceuticals and people create trials that make more patients feel like I felt when I got placed in mine, and how can doctors make their patients feel comfortable enough to even think about the idea of being placed in a clinical trial? Because I think the biggest thing within all of this is being able to trust. If I walk into somewhere and I've had a visit before at a primary care doctor that didn't know my pre-existing conditions, and she took my blood pressure and told me I need to stop eating so much salt, not knowing I have a genetic variant of kidney disease. Things like that make people not trust the doctor, but I made to feel very trusted in that moment, and I'm blessed that I made that decision because I'm doing great now. So,
Thank you. Sorry. And he has touched on an important point, right? I mean, there's been a lot of misconceptions about being in clinical trials, and we're doing a lot in the industry right now to address those misconceptions, right? One of the things we did that was done in this trial is that they made it less burdensome. They made it easier for him to participate. A lot is being done in the industry right now to ensure that not only your rights, right, is protected, your dignity is protected, but then we're not creating unnecessary hurdles for you to scale through just to become a participant. Now, we've heard about misconceptions about participating in clinical trials, but I'm sure some of you may have also heard about concerns about genetic testing and screening. I would like Jorden to share his opinions and thoughts around how he felt, because even though Joshua is in a clinical trial, Jorden is able to manage his care outside of a trial setting. But of course, he had an experience as well with the testing process. And I would love you to talk about how your misconceptions around genetic testings were addressed through your experience.
Again, I'm very, very blessed that my brother was diagnosed and he was as proactive and open-minded to things that really, honestly, it would have taken me a much longer time to be open to it. And if he didn't get diagnosed and it was just me, like, there's almost no way I'd be here, one. And I probably wouldn't have been I probably would have done things a little bit differently, honestly. So I'm sure a lot of people that are sitting here thinking the same thing, like, you want me to get what tested? It's like, it's really one of the most sensitive things you can think about. It's our genes. So it took a while for me to kind of wrap my head around it. But just for example, when we got both our genetics tested, we learned that Josh, he had the G1 variation. I had the G1 G2, and just knowing that information right there, opened up the door to so much knowledge to come, because Joshie is a bit more advanced than I am. And I would have assumed as a brother that, an older brother, I might have been a bit more advanced, but we know now that with more research that G1 may actually be a little bit more aggressive than the version that I have. So that small detail led to us understanding a lot more, and also allowed me to think about, the future. I don't have kids now. I'd love to eventually, and like, I got to be realistic of, what that can mean for them in the future, as things continue. And as far as overall concerns, you got to think about things like, of course, like Henrietta Lacks, there's historical context of how things have been utilized in the past without the proper consent in place. Also think about at a time frames of like 23andMe data breaches. It's like, okay, who has my information? How's it stored? Where is it? Does the sample get, like, is it gone after this is done? Or what is it? And I had some of my concerns addressed, such as like, okay, your personal information is stored in a separate area rather than where the actual sample that was utilized. And if I ever want that destroyed or removed or no longer utilized, I can just voice that and that will be the case. So of course, just understanding the reality of how as a community we have been let down in a lot of scenarios. So it took us sitting down as a family, because it sparked a lot of conversation amongst us, not our immediate family, but everyone has an opinion. It became very hard to really think, okay, we're the ones living with these diseases. We got to be like realistic as to what we're going to do for our lives to continue and how we're going to move forward. So for us, it was a blessing. It's allowed me to learn a lot and kind of shape how we're going to continue to live our lives as time goes on.
Thank you so much for sharing your story. And one important element is the fact that Joshua and Jorden, they have a right to withdraw consent. So they have to give consent anyway before you do anything with their samples or their test results. And they have a right to withdraw that consent at any time. So it's good information for us all to know. Dr. Crenshaw, can you please reflect on the recent discussion and what you think the benefits of participating in clinical trials are, as well as in getting genetically tested?
Absolutely. Let me ask a question. If there was a disease such as APOL1-mediated kidney disease, and there were cures that were available, how many of y'all would want you or your family members to be treated? Show of hands. Pretty much everyone in this room. This is why testing, genetic testing, is so imperative. And the reason why is that right now, there are 4 drugs perhaps that are going to be on the verge of being passed for approval to be utilized to be able to treat this disease. But what's going to impact that is the number of tests, as far as research testing that is being done and conducted, to be able to justify the use of these therapies. And then also for everyone in the room who understands cost, you understand drugs cost. Well, what we have to have now is a justification from a research perspective that will allow us to utilize these drugs in a cost-efficient manner where everyone can have access to these medications. And so I think that with that alone, that gives us the incentive to be able to go out and be tested, because not only are these drugs going to be allowed just for you, but think about your generations to come. Think about those that are coming down the family tree who may have this disease or have the high-risk variants for this disease. I think it's going to be really important that we consider testing, understanding now that it also in history, we understand the infamy behind genetic testing. But also there's an infamy behind testing whereby in certain clinical trials, we have been under-tested. And so as a result of that under-testing, we have been counted out, particularly African Americans, in certain research trials that when therapies came along, it was found out that some of these treatment styles were not as effective in people of color because they were underrepresented in the trials. And so this is why I want us to be forward-thinking, not just for ourselves, but for our future, to understand the importance of genetic testing, because many of these drugs that are going to come down the pipeline, which we are right on the verge of having these drugs at our disposal for the treatment of APOL1-mediated kidney disease. And this is why I think genetic testing and participating in clinical trials is so imperative.
Great. So I have a few more minutes and then we'll go into question and answer. So I'll give you maybe 30 seconds each, right? just give me your final thought on what you think the future of AMKD diagnosis and care should look like.
Like Dr. Crenshaw said, I think there's just so much hope at the moment. In this space, I've been in it around like 4 years now, and I've learned from people who were diagnosed before me, maybe 10 years ago or 20 years ago, and where we're at today. I think as a patient and as somebody who's going through it myself, I just feel so hopeful, and I just hope there's a lot more people and young men or young women who may be diagnosed like me at a younger age and it's caught early, and they can have a similar story like mine, who still get to go to college, still get to be with their friends and live a happy life, and not let their diagnosis or their health problem be a problem, you know. So I think just some more people who are able to feel the hope when they get diagnosed instead of being diagnosed and feel like there's no option. So,
Jorden?
I think it should look like this. You know, I think it needs to be community-led, patient-led, family-led, having everybody having an opportunity to have a seat at the table and really contribute to the things that affect us directly, you know, from now to all future generations and past. So more things like this, getting direct to the heart of where the people that we're hoping to help and get towards and help have more opportunities. So again, hopefully more collaboration, more of us getting together in these opportunities and just keep spreading the word.
And Dr. Crenshaw?
I think we're at a wonderful juncture in my profession, particularly in the field of nephrology. We have drugs now that are on the verge of being passed for the mitigation of this devastating disease. But I'll have to say, every time I go to a dialysis facility and I see patients who are on dialysis 3 days a week, it gives me the inherent passion to continue to do whatever is possible to spread the knowledge and information on this disease, along with other diseases related to kidney disease. Thankfully, right now, we actually have an ICD-10 code for this particular disease. And so we're seeing so much momentum around the country as far as what this disease is about and as far as how we can treat this disease. So I'm very excited in this time regarding the field of nephrology and for APOL1-mediated kidney disease.
Yes, and I'm hopeful as well. And I cannot thank our panelists enough. Thank you so much for your courage and your willingness to share your story. So today we've learned about AMKD. We know that it's not just a health issue, it's a health equity issue, right? Awareness, early diagnosis, as well as participating in clinical trials could potentially change the trajectory of this disease. However, we all have a role to play if we really expect this change. So let me put out a challenge to all of you. Well, first one, please discuss AMKD with your families and friends, doctors' network. Awareness starts with a conversation. Second, please encourage kidney screening, especially for those of West African ancestry who may have all the other conditions that Dr. Crenshaw just discussed earlier. And then third, advocate for clinical trial participation, because representation in clinical trials by all of us is very critical to ensuring that the medicines that are on the market works for everyone. So before you leave today, before the Q&A, I do encourage you to come to the AstraZeneca's table behind this auditorium. You can get more educational materials and resources about this disease. We also have a second table on the C level where you can learn about our lupus trials. We have members from our sites there to answer any questions you may have. And if any one of you have heard about NEFCure, it's an association who is a community partner of AstraZeneca. They have a table right next to us as well. They can tell you a little bit more about their important work in this space. So finally, what I want to leave you with is together, right? We can turn and we can make equity a practice and turn awareness into actions and then actions into better healthcare outcomes for all of us. Thank you so much. And so now let's ask your questions.
That's a wonderful question. And so, again, with the understanding that me as a nephrologist, by the time most patients see me, they're at a late stage 3. They're what they call a 3B CKD or chronic kidney disease. And so it's not uncommon, and I'm seeing people in stage 4 and stage 5. Stage 5, by definition, for those in the room, this is when the kidney function is less than 15%. And when you're at stage 5, this is the indication that you will be considered for dialysis. And so I see people at the stage 3 level, which indicates that their function is at 30%. And when you get below 30%, certainly between 15% and 29%, you're at stage 4. Many of my patients are presenting in that fashion. And so what I advocate for every patient in the room, and this is why I want patients to be proactive. When you see your doctor, there are a couple of things you're going to ask, particularly everyone in this room. Number one, are you at risk for kidney disease, which can be identified by a blood test? There's one test that's called the creatinine level that can give you some indication as to whether or not you have kidney disease. But also, what is critically also important, that you ask your doctor, do you have protein in your urine? And many times when the patients come to see me, or when I have other forums like this, it is unfortunate that many people in the room have not had their urine checked for exposure of protein. Let me tell you, if you see protein in the urine, even microscopic levels of protein in the urine, those are early indicators that you have kidney disease. And so I like to tell everyone in the room to be proactive, that when you see your doctor, you're going to ask, doctor, do I have any underlying exposure to kidney disease by blood test and also by the urine? Because I have many patients, and particularly patients with hypertension and diabetes, who have not had their urine checked for the exposure of protein. And let me tell you, when you have protein in the urine, I say this again, that is one of the earliest markers that you have underlying kidney disease. It's a very good question. And this is very common. She asked the question, why is it that essentially patients are referred later to nephrologists when all of these other medical conditions are being addressed? And I like to go back and say, fundamentally, everyone in this room, to her point, that if you have underlying hypertension or diabetes, it is imperative from day one that you ask if you have underlying kidney disease. I see patients all the time. When I see them, and again, I said in my talk, the first time they see me, the first question they're going to ask is, doctor, why am I here? Because they don't know. And when they understand that they've had diabetic kidney disease, many times I can look at that patient due to the evidence of protein in the urine and tell them that they've had diabetes-related kidney disease for decades. So this is what you have to understand. Again, everyone in this room, I implore you to be proactive to make sure you're getting the blood test, but also getting your urine checked to see if there's any evidence of protein. And thankfully, we do have wonderful medicines on the market that can actually reduce the amount of protein in the urine and actually protect the kidneys from developing significant scarring and damage, ultimately leading to dialysis.
I wanted to say this very quickly too. I'm sorry, just to piggyback up what you said and to answer your question about why doctors do certain things. Not all doctors are as smart as this guy. They not. Not all doctors know all these details about kidney disease. So you have to also learn to be able to advocate for yourself. I've met so many people on this journey where they've gone to their doctor and they're letting them know, hey, doc, I got this going on. I got this going on. Oh, it's probably just that. It's probably just that. Nah, you probably need to find a new doctor, like for real, because not all doctors are as smart as him. So I just wanted to answer that. I've been holding that in, so.
There's a standard of care for vaccinations, a standard of care for mammographies. What is the standard of care for kidney? Especially sensitive heart, kidneys, and our metabolic system with diabetes. The trilogy needs a consistent. We know that as providers. Why aren't we making it a part of the gold standard of care? And how can we affect that?
It's a wonderful question, and I'll go ahead and tell you Ma'am, you bring up a wonderful topic, and right now it's at the top of everyone's agenda when you go around the country, and particularly in the space of nephrology. And this is where we talk about healthcare equity. Okay, we have to understand that we do have an equity crisis whereby certain people are getting tested earlier than other ethnic groups. And again, until that is slowed down, again, this is why education is the key. Knowledge is power. You have to be very proactive as these committees in nephrology continue to raise awareness, but also continue to heighten the importance and the sensitivity on kidney disease testing in this country. It's going to start with forums like this, which then the momentum when you have forums like this transcends over into policy. Again, this is why I implore you also about being genetically tested and also considering clinical trials, because the numbers speak volumes when it comes to laws being passed, when it comes to evidence-based medicine being emerged, i.e. the sensitivity to test earlier and everyone, but more importantly, in the people who are affected by kidney disease the most, and that's those in this room.
Thank you so much. I know we're running out of time. So knowledge is power. Now you have that power. Please use it. Let's put our voice together and start to push for change in this space. We will have Dr. Daryl Crenshaw at the AZ table. We also have another doctor here, Dr. Mike McCarty is also going to be at the table. Please come. We'll be able to answer any of your other questions that you have in this space. Thank you.